welcome. Thank you for attending us today for this webinar with Fullscript and Dr. Paul Hrkal. My name is Kaylee. I'm part of the marketing team here at Fullscript, and we're very excited to have Dr. Hrkal here with us today to talk anxiety and nervous system dysregulation in post-concussion and whiplash syndrome. Before we get into the presentation, though, I just want to do a little housekeeping. A reminder that this is being recorded, so whether you have to drop off early or you can't attend the whole thing, you will get access to the recording after the event, along with any resources we can provide as well. All webinars also live on the Fullscript website at fullscript.com/webinar, so you can always find it there. And we are hoping to have some time at the end of the presentation for a live Q&A. So throughout the presentation, if you want to add questions into your dashboard, we'll hopefully have some time towards the end. So as I said, we're very excited to have Dr. Paul Hrkal with us here today. Dr. Hrkal is a naturopathic doctor and member of the Canadian and Ontario Associations of Naturopathic Doctors. He has a special interest in neurological health, chronic pain, and brain injuries, and has written and lectured extensively on these topics, which include over 100 webinars, podcasts, and live presentations. He is a member of the Scientific Advisory Board of the Complete Concussion Management, which is an international leader in research-based concussion management education, and is the co-founder of the Concussion Fix program. He's also a member of the Pain and Wellness Center team, which is conducting an ongoing Ontario Ministry of Health funded study assessing the multidisciplinary approach to pain management. He has experience in the natural health industry as well, where he has been a scientific advisor and medical director for nearly a decade, educating clinicians and formulating science-based products. I mean, I could go on and on. This is an amazing bio there, Dr. Hrkal, but I will pass it over to you. Take it away, and I'll rejoin for some Q&A at the end.
Thanks, Kaylee. Appreciate it. All right, thanks everyone for joining me. I know everyone's super busy here. So I'm really excited to kind of be here to share something that obviously I'm very passionate about. As you can tell from my bio, this is what I do day in and day out with my patients. And one area that we discussed when we were kind of creating this topic was, you know, what can we talk about when it comes to mental health and concussions? And there's a huge connection here that I want to just kind of give you some clinical insights in. So here's my disclosures. I think Kaylee kind of talked about it already, but here's kind of what I want to talk about today. This is the journey I want to take you on. And some of you are coming from different walks of life. Maybe, you know, I'm sure if you're a clinician, you've probably seen people with concussion. Maybe you've seen people that have had post-concussion syndrome. But we're going to get people on the same page right off the start. My goal today is to try to make sure that everyone walks away from this presentation with understanding the relevance of concussion to their clinical practice, even though they may not be, this may be their focus, but we're going to talk about how important it is because it is one of the most common neurological conditions that you will see with your patients. I want to also make sure everyone understands the key pathophysiology. I'm a big fan of functional medicine and really understanding how everything fits together. When you have a good understanding of that, then you're going to have a much better and more successful time in practice. We're going to specifically.
Sorry, I'm so sorry. I'm going to jump in. I'm not sure if you're sharing each slide specifically, but we can just see an overall. Oh, you might. There. That's probably a little bit better. We can see our journey slide. I'm not sure if you were going through them or if I just wasn't seeing them. So sorry to
okay, that's okay. No, I'm better stop me now than it was when we keep going. So hold on. So when I go full screen, you can't see it?
I see, so, I mean, correct me if I'm wrong for the attendees, but I see like the still the PowerPoint like back end. So I can see the slides on the left. I can see our journey screen, but that's odd.
Okay, well maybe what we might have to do is try something a little bit different here.
Was it presentation mode that you were trying, or were we trying something different?
Yeah, I was going presentation mode,
weird.
But it might be something to do with my. I'm going to stop showing my screen here for a sec, and then I'm just going to show my whole main screen. We're going to go from there, okay?
Yeah.
Just going to get everything.
Sorry to bug you, but I wasn't sure if it was on my end or if everyone, but it looks like people were seeing the. Right.
Okay, let's see here. All right.
There we go. I can see our
I
journey
think we'll
slide.
see it now. Oh, okay, perfect.
Okay, sorry.
Okay,
Thank
so
you.
we're good
Take
now?
it away.
All right,
Yes.
thanks. Okay, sorry about that. Okay, so I want to make sure that everybody understands the impact on specifically on mood. There are many other factors we're going to be discussing. We'll talk about other systems that play a key role in this. This is not meant to be a fully comprehensive assessment and presentation on everything to do with concussion. I have a whole course that we've put together on that, and it's way beyond the scope of this. But I really wanted to talk about what you can do, take away tomorrow with your patients when it comes to especially addressing mood. And then we're going to really talk about clinical pearls. And I really I will try to respect everybody's time with this because we do have 60 slides I want to get through in about the next 60 minutes. Okay, here's a couple, I kind of consider them fun, interesting facts, but it's about taking concussions from, the microscopic view that sometimes we see with the patients right in front of us, and then taking a step back and understanding what's the impact on our patient population, what's the impact on our community, what's the impact on our entire country and where we live. It's the most common neurological injury. A lot of people don't think about that. They think about probably some of the more well-known ones, the ones that kind of get a little bit more recognition. People might think, oh, what is multiple sclerosis or dementia, getting most of the attention. But concussion is the most common neurological injury with, in the US alone, over 3.5 million cases of concussion every single year. And when it comes to concussion, what's neat about it is that there's a lot of research being done in the sport world. So we have a little bit more specific data. Obviously, that's a key focus for people being able to function and play and participate. About 20% per year of play, people that are participating in any sports get a concussion. We'll talk about some of the ones that are most common, but that's pretty interesting because if you've played a sport for 5 years, the chances are that you're going to at least sustain one concussion in that year if you look at that data. That's pretty interesting, and that definitely does drive home the point that it's not a matter of if, it's a matter of when a person gets exposed to this. A key takeaway point, again, that usually I drill into a lot more detail, but suffice to say that symptoms do not correlate with neurological recovery. Sometimes symptoms are brought on days later. Sometimes they're brought on by an additional hit or something very innocuous to their head. They might bump their head on a car door after they sustained a concussion in their sport, or they fell and slipped on ice, for example. So it's key to understand that it's not always driven by symptoms. There has to be the understanding that there's a physiological recovery that has to occur, and that is different. And usually symptoms go away after about 7 days, and physiological recovery takes up to 30 days to fully recover. Post-concussive deficits occur with very little, if any, observable pathology. This is a key takeaway because a lot of reason that this is one of the most common neurological injuries, but also the most poorly understood neurological injuries, is that there isn't anything that a person can see. If you fall, break your bone, you can x-ray it and image it and figure out where exactly that break is and treat it accordingly. With concussions, it's very symptom-based. Usually you rule out the worst case scenario, like a brain bleed with a CT scan or MRI, but you really don't have anything that those show up that have any sort of clinical significance. So this is a big obstacle for the conventional system, and I think it's one of the reasons that it often, again, like I said, slips through the cracks. Little point on terminology. We're talking about concussion because it's the most commonly used term, but throughout my presentation, even in the literature, concussion is interchangeable with MTBI. M stands for mild TBI. Sport-related concussion is SRC. And then another key factor, just to understand when you're diving into the research, you'll even see it through some of my slides. Mild traumatic brain injury or concussion is not the same as moderate or severe brain injury. These are catastrophic type injuries that there's loss of consciousness. They have a very different Glasgow coma scale than people that have sustained a concussion. Sometimes you do not need to have a loss of consciousness for concussion, but usually do in moderate and severe concussions. So they're not the same as TBI. They are part of a spectrum, but there is some really key differences, and I'll kind of try to share those as we go. There's this term called post-concussion syndrome, and we'll talk a little bit more about what this entails. But basically, it's if symptoms last for more than 30 days, symptoms and dysfunctions. Usually, one of the key ways of helping your clinical guidance of when a person can return to play and return to function, return to school, is when they're able to pass an exertion test, which is increasing their heart rate. So it's not just about, I don't have any sort of symptoms, but it's when I go for a run, I go for a jog, or I get in front of the screen, this flares up my symptoms. That still is part of concussion. And if that continues for over 30 days, that is what we can term post-concussion syndrome. A lot of the patients that I see are months and years out. So I rarely deal with mild traumatic brain injury in the acute phases. I deal with it mainly in the chronic phases. And that's just the nature of our healthcare system. Naturopathic doctors are usually the first line. Whenever you're doing a health history, so this is relevant to people that are just kind of thinking about how they're going to implement this in their practice. Never well since sustaining a concussion. Now, this may not be obvious on your initial intake. It may not be obvious in your line of questioning, but it definitely should be something that you should be considering as you're going through a new case, especially if a person's had a car accident and they say, yeah, I have a bunch of health issues that have popped up since then. Make sure that they haven't had a concussion. Whiplash also is almost identical to concussion in terms of symptoms, even though it is pathologically and mechanistically different at the onset. But afterwards, having post-concussion and post-whiplash syndrome, almost impossible to kind of tell those two apart from a clinical perspective. A couple little things about males versus females. Males sustain more concussions below the age of 25. You think that if I was just to poll the audience right now, before you saw this stat, most people would think, yeah, I think males probably get more concussions. And a lot of that is majorly skewed and biased because of American football. American football is primarily, not exclusively, but primarily a male-dominated sport, and it happens to be one of the sports that have the highest rates of concussion. Obviously, most males play below the age of 25, but after the age of 25, females become more. There's increased incident in concussions in females after the age of 25. Sports with the highest rate of concussions, I already mentioned football in males. Soccer in females is the most common concussion sport. And women also are more susceptible to concussions. So not only do they have a higher number after the age of 25, they are also more susceptible. If you're looking at sport equivalents, like for example, soccer and soccer or rugby and rugby, women are at a 1.56 greater chance of sustaining a concussion. And they also have a longer time to recover in the acute phase and also in getting treatment and getting back to sport. There's a number of reasons why this is the case. There's a number of theories, I should say. One of them is males have a stronger neck from an anatomical perspective, so they're able to prevent their head and their neck to move forward in such a high velocity. One of the big things that causes a concussion is the G-force that happens in terms of the acceleration and deceleration when there's a hit to the head. One of the theories is that maybe women are more susceptible. There are, these theories, by the way, are not locked in stone. They continue to be debated. Another one is the endocrine theory, which obviously females are unique to males when it comes to their hormones. And so we'll talk a little bit about some of these differences, but basically the estrogen and progesterone play a both protective and also actually have a susceptibility. Progesterone generally is neuroprotective, and so if you get a concussion, the research shows in the second half of a woman's cycle, they actually are an increased risk for longer recovery times and lower cognitive scores. You think that that's the opposite because progesterone should be higher, but you lose the protective effect of progesterone because the pituitary is disrupted. And then one thing that I kind of want to make sure everyone's on the same page about is that I firmly believe that no one person can treat every aspect of a person that has concussion, especially in PCS. I often talk about patients about having a sliver of the pie that needs to be addressed. And most people, just think about this for a second, most people that have sustained a brain injury usually see their family doctor, then they might get referred to a neurologist, then they probably get referred to a physiotherapy or someone on the manual care team. But after that, that's really where it stops. And they're missing half the pie in terms of making sure that they're addressing all these things. So my perspective is that I don't do everything. I know some of my colleagues try to also do some of the visual, vestibular, some of the cognitive testing. They dabble in the psychological side of things. I'm of a firm belief that I want to create a team around me that's going to be able to deal with some of these things. So my focus today is going to be addressing the mood from a metabolic, cellular, and hormonal perspective. However, all these aspects are really, really important, and they should be considered. So think about this from a patient's perspective. They need to have someone solid in really every single one of these corners, ideally. So let's get everyone on the same page. I'm not going to spend too much time on this, but I just want to make sure everyone understands what's actually happening in concussion, because again, it is one of the key things that we need to understand to then see how it impacts mood. So we know that there's a concussion. There's at least 75 G's of force that has to happen at a minimum. There's a stretching to the axon. The axon actually in the brain gets stressed and stretched, and that causes damage. And at the same time, almost immediately within minutes and definitely within hours, there's inflammation that occurs. Microglia, these are key cells. I hope everybody listening has heard of them before. I'll tell you a little bit more about them. They're definitely the key players when it comes to the inflammatory cascade in the brain. And then there's this excitotoxicity and impact on the mitochondria. So there's a quick increase in energy as the mitochondria is trying to maintain homeostasis to compensate for that axonal sharing, to compensate for inflammation. However, it's never enough to maintain. And then there's a kind of a suppression, a hypometabolism that happens after mitochondria become more dysfunctional. And short term, these are all healthy things. These are helpful things. They are part of the inflammatory cascade, just like we know about any sort of acute injury. However, the issue always is that is the body able to keep these systems and keep these processes in check and not allow them to become chronic? That really is one of the key underlying factors in almost any chronic disease is, are we able to manage acute damage and not allow it to become chronic and unremitting? And all these things together are responsible for symptoms. So this is another way of looking at it. This is a paper from JAMA in 2015, just kind of looking at a traumatic brain injury. So here you have a mild traumatic brain injury. You don't really have damage to the skull. That's just more for graphic effect. But some of the metabolic things that happen underneath it definitely can happen. So first thing that you're going to see is this big yellow barrier. These are astrocytes. They're responsible for the blood-brain barrier. And that blood-brain barrier can get disrupted. Again, in most cases that recover, again, research shows 80 to 90% of mild traumatic brain injuries recover within a week to 2 weeks. Some studies show that can be as low as 70%. The other 10 to 30%, they go on to what we call PCS. We'll talk about that in just a second. But you can see some of the metabolic processes that are happening. There's obviously multifactorial things, but basically what I want to show you is the changing of shape that occurs in some of these cells, like the microglia. These are the latent, this is the watchful state, and then they change, they lose a lot of their processes, and they actually become pro-inflammatory factories. They become activated. There's blood flow changes that happens, and then potentially leaky brain that happens. Just like leak, yeah, so there's a lot of parallels between some of the barriers. Now, there's this concept of microglial priming, and this is really, really important because it directly plays a role in mood. We really need to understand that depression, anxiety are now being looked at as inflammatory conditions. And in post-concussion, this is absolutely no different. So again, breaking it down and zooming in on the microglia, you can see concussion, or more severe. And the more severe something happens, the greater chance that you have more priming or more activation. And so again, most cases, 70% kind of go into the resolve phase, and then the symptoms go away within a week or two, and then people get back to normal. As far as we can tell, there's no lasting effects from concussions. There is a lot of controversy around that, especially around the NFL and ex-players and ex-hockey players looking at potential long-term effects of sustained concussions. I think that they probably had more severe brain injuries, and they probably went down the unresolving pathway here. And then you get kind of like this prime state, and then finally hyperactive. And there's any sort of challenge to the immune system. This can be a food-based challenge. This could be another infectious or inflammatory challenge. And so now these microglia are locked in a prime state, and they are just spitting out inflammation. And clinically, what I see with my patients is that no matter what they do manually, they are not responsive to any treatments. They're going to constantly be saying, I have this cognitive dysfunction, I have this brain fog. Their mitochondria are not properly functioning because of the high level of inflammatory cytokines. Remember, mitochondria are the sensors inside the cell. Again, this is a kind of a deep functional medicine dive, but you've maybe heard of something called DAMPs and PAMPs. So you can see, again, these are pathogen-associated molecular patterns or damage-associated molecular patterns, and the mitochondria are the organelles that are sensing those. So they are definitely looking and sensing that, and that is translating into symptoms. So we know that these immune challenges can happen months after a concussion. So just understand that's key in depression as well. And then this is a really good schematic that looks at just how microglia and impact on the brain impacts every other single organ, especially the gut-brain axis. So I mentioned we will talk about this. Again, I have a whole lecture just on this and diving into all the different nuances. But for the sake of this particular conversation right now, I just want to show that within 3 hours, there is an increase in intestinal permeability. You can see that right here in C. Structural changes happen in the gut after an injury, microglia are activated, and then you have a systemic pro-inflammatory response that happens. Now, you might be thinking, the body's intelligent. It doesn't do things that usually, in most cases, it doesn't do things that don't serve a purpose. So I think in this purpose, there definitely is clearly a need to increase inflammation to promote healing and ultimately promote the cleaning of the injury and the resolution. However, think about all our patients. They are not in a state where they're able to regulate this system very well. They might already have existing inflamed intestines, inflamed and more permeable lining of the digestive system. They might already have an autoimmune system that's brewing, that's hyperreactive, that's brewing under the surface, autoimmune conditions like Hashimoto's or Crohn's or colitis. So there's multiple factors that you can see that this kind of resolution system might break down, and a person's stuck in ongoing secondary injury and ultimately leading to sustained neuroinflammation. I love this graphic. I think this graphic does a phenomenal job of kind of highlighting all the key areas that as functional medicine and naturopathic physicians and doctors we look at. I'm really looking at some of the key things: neuroinflammation, blood-brain barrier permeability possibility. You're looking at the vagus nerve, the key connection point between the gut and the brain, and then obviously the key role the gut plays in propagating this inflammatory response. So we're going to come back to this because it's really, really important, and I'm going to talk a little bit more about the vagus nerve. But I want to talk a little bit about some of the other things that might be contributing to mood dysfunction, because we're now getting to the key topic that we're here to discuss. But again, we have to understand, and I'm sure everybody on this call knows, hormones play a key role in mood. And so this was a study done out of University of Toronto very recently, looking at sport-related concussions, so mild traumatic brain injuries in athletes. And what they found in acute situations, within 7 days, prolactin went up, progesterone went down, and DHEAS went down. And the green here are significant, statistically significant. Lower DHEA levels and progesterone related to increased symptoms and longer recovery times. prolactin also was correlated with time to medical clearance and cognitive symptom reporting. And what I kind of find fascinating is that there is some similarities between different types of symptoms a person might be sustaining, because there are multiple categories. In this case, they've broken down into 4 in terms of symptoms and what a person might be experiencing after they sustain a concussion. Some people experience very somatic symptoms, so bodily aches, pains. Some people it's mainly fatigue. Some people it's mainly cognitive. They can't function. They can't process. Their executive functioning is not working. And then some people are very emotional. This is anxiety, depression, sleep disturbance. They generally have very similar patterns, but I just wanted to include that to show you that there is a difference slightly between some of these different phenotypes. So ultimately, again, we know the HP axis, we know the gonadal axis is impacted, and we know that there's a disruption in cortisol production. And everyone on the call knows how important and how clinically relevant that is. Now, again, 70% of people, they usually are able to self-regulate and get back to a normal stress response. However, there are people that don't go back into normal, and they actually proceed into a further disruptive HPA axis. And I'm going to talk a little bit more about this because there's a couple key additional nuances when it comes to the endocrine system that don't show up in the acute phase, but can show up to a year after. That's a really key point. So stay with me on that. I already mentioned some of these key takeaways. I think everyone can kind of read this over for their own benefit. We know the impact of adrenaline and epinephrine. We know the impact of the HP axis. Remember, the HP axis is not just about energy. It's not just about cortisol, but it's also about regulating gut function and other symptoms and systems. The heart rate variability we'll talk about just a little bit, and how it impacts the psychological symptoms. But if your adrenal system's off, your gut lining is going to be much more susceptible to injury. You're going to be at a much increased risk for hyperreactivity, allergies, food sensitivities, microbiome disruption itself. So key thing to remember. Okay, so now we've kind of set the table. Everyone's on the same page of understanding what are some of the key metabolic changes that happen after a brain injury. Understand that there also are structural changes that are occurring. There could also be visual system changes, which are definitely directly correlated with some of the cervical structural changes that happen. We talked a little bit about the inflammatory changes, which is AKA the immune system. So now let's talk about some of the psychological changes after a concussion. So we know that there's a mood disturbance that occurs after a mild traumatic brain injury. Usually this is transient, that kind of goes away after about 3 weeks of injury. Anxiety, depression, both of these, again, are some of the more common things. Most of the times it's transient. A lot of my patients will report that they felt more anxious, they felt fatigued, they felt like they were in a state of fight or flight, which we'll talk about in a couple slides, and they definitely had sleep difficulties. 33% of athletes experience some sort of anxiety after a concussion, so quite prevalent. So that gives you just an idea of the mental, emotional impact, the psychological impact of concussion. Depression is an interesting one because there's a lot of overlapping symptoms with being depressed at this age group for a number of other reasons. This also could be further exacerbated by a lot of very poor advice that most primary care providers give athletes and other people that are sustaining concussions. This would be a good little sidebar just to look at the worst advice that acute concussion patient can get is being told, go home, don't do anything, be in a dark room, and don't come out until your symptoms go away. That is the most anti-evidence piece of information advice that they can be given. And believe it or not, it happens every single day. I hear it all the time because the research has not caught up with primary care yet. The evidence-based advice, as you know, even 4 or 5 years ago, there's every kind of like 4 years as a consensus statement that's released. So the last one was Berlin, and they were looking at The most important key takeaway in acute is you do not want to just stay in the dark and do nothing. What you want to actually do is you start getting out, being a little bit more active. Exercise seems to be protective and beneficial, usually around 24 to 48 hours after the initial injury. So after that first kind of traumatic event passes, the kind of the acute stress and shock of the situation wears away, a patient should take stock of their capabilities and basically do subsymptom exercise and subsymptom movement and action. That might be getting up and walking around the block if they're an athlete and that's all they're able to do. But sitting in a dark room away from all screens with sunglasses on actually slows down recovery. A couple other factors in psychological factors in concussion. There's this idea, and I've been fascinated by the idea of resilience and coping because I see it with my patients all the time. The question that really is at the forefront and on the back burner, depending on what I'm dealing with all the time, is why do some people go on to get post-concussion syndrome and other people don't? What are the factors that contribute to that? And maybe if we understood those factors, we could maybe reverse engineer it and help a person that is in PCS go back the other way. One of the ideas in the psychological realm is this idea of high versus low adapters. Low adapters are those people that have stronger negative beliefs. They are going to have negative self-talk. They might already have some predisposition to depression, anxiety. They might have past traumas. They report higher symptom scores than high adapters. High adapters don't necessarily mean high achievers because some of those people have the strongest negative beliefs, but high adapters are more that they have more positive beliefs and less negative beliefs. From a chronic situation of more than 6 months, medium and high adapters had mostly recovered when low adapters had not. And it was one of the most predictive pieces of diagnosis that a person could, that you can find that determines if you are going to have a worse health outcome after an injury up to a year. So that's absolutely fascinating. There's also this concept of cognophobia. We, as a patient sitting there in our office, and we're talking to them about how they're feeling, and I kind of get this all the time. And I'm sure anybody that's an experienced clinician is probably already pretty good at this, but this is a good reminder in the context of concussion. A lot of people are going to overestimate their cognitive dysfunction. And a lot of times it seems like patients with concussions may kind of say, you know what, I can't do anything cognitively, aka cognophobia, because it brings on symptoms. Because they're so symptom averse, they kind of fallen into this fear of doing anything cognitive, which may bring on some of their symptoms. And this is potentially a way of looking at some of those, another way of looking at low adapters versus high adapters. And this last piece of information, research shows that cognitive behavioral therapy, which is a psychological intervention, was superior to improving self-reported cognitive dysfunction over cognitive rehab. So many people want to treat concussion as purely a physiological dysfunction. And really, depending on what practitioner and provider you go to, they're going to tell you, you know what, I can treat concussion if I just treat your neck, or I can treat concussion if I just give you vestibular rehab or visual rehab or whatever it might be. And it might even be like, eat this diet and it's going to cure your concussion. That is just not the reality in clinical practice. You definitely need to consider the psychological aspect of concussion recovery, especially in post-concussion syndrome. So based on that, the research, that particular research on cognophobia and high versus low adapters, one of the key clinical pearls is especially if you're dealing with acute concussions, patient education, telling them what's going on, telling them advice that is going to be fruitful for them, like don't stay home and just sit in a dark room, understanding and reassurance, all these kind of key basic rapport bedside manner practices have all shown to be a positive impact on people with cognophobia and have poor adapting capabilities. So now let's talk about post-concussion syndrome, because we've been kind of already talking about it, but just so we can talk a little bit more about that, because that's what most people I think on this call are going to be seeing patients in. They might be seeing patients that might have insomnia, and you've gone through all the different things, and they're not responding to your typical remedies, your typical protocols, and now you have to start taking a look at what are some of the other potential things in their health history that could be triggering this, and this hopefully will kind of round out your approach a little bit better. So these are some of the key symptoms that you experience in post-concussion. It's not the only one. So I'm just going to kind of tell you a little bit about what some of the things that are going on under the surface. Again, these are potential things that are occurring in a patient, but not all of them necessarily have to be in place to have post-concussion syndrome. In my experience, it's a combination of all of these, but a person usually has a particular obstacle that is specific to one or two of these areas. I'll give you an example. A lot of people with concussion and post-concussion syndrome is that they're going to have some sort of neck pain. They're going to have some sort of headaches. You can see that's number one here on the list. And you can see that soft tissue damage of the neck is number one on the list, often is the number one reason why you get headaches. There's a tremendous amount of referral patterns that occur, but most of the time, due to poor management, they've never actually properly been assessed from a neck structural perspective. And there's been treatment on their neck, and in a lot of cases, patients will say that I actually feel a heck of a lot worse after I'm getting neck treatment, and then they discontinue treatment. Where what we know, and people that have treated concussion from a manual perspective will tell you that usually is the sign, if symptoms are exacerbated, that is where we need to focus our attention. We just maybe need to change the intensity or the frequency of or the type of treatment that we're doing. So that is a very common obstacle, but you can have obstacles in every single one of these areas. And obviously the areas that I focus a lot on with my patients are the autonomic, metabolic, endocrine, blood flow, and then the inflammatory perspective. And so I really don't love the term post-concussion or post-whiplash syndrome, because at this point it's something that just describes what happened in the past, but it doesn't describe what a person has right now. At this point, it really is good functional naturopathic medicine that is going to understand some of these underlying issues and treat them. And I think it's probably more accurate to call it inflammatory syndrome, but inflammation isn't the key obstacle in every single person's case. It could be. Their gut microbiome might be a key obstacle. Deficiencies could be a key obstacles. These are all the things that, as somebody that is addressing that metabolic side of brain injury recovery and wanting to balance mood, you have to address each one of these areas. We're going to talk a little bit more about dysautonomia in just a second. It's super important when it comes to mood. Vagus nerve is one of my faves to use as a window into the brain and to use as treatment. Impaired gut-brain axis, that definitely is a key obstacle. Again, stress, HPA axis dysfunction, and then finally the psychological. I just have a patient that I'm working with right now that comes to mind that there definitely is neck dysfunction that we're treating. However, right now, I actually recommended that they need to be on some sort of SSRI or herbal version of an SSRI, because they have such instability in their psychology. They're always falling in and out of these depressive and anxious states that we need some stabilization. So psychology in every single one of the sub kind of focuses within psychology, including pharmaceutical medicine, including mindfulness, psychology, psychotherapy, all need to be considered. So what I want to talk a little bit about here, and this is how we're going to connect back into the vagus nerve and connect back into the metabolics, but there is a strong connection between the psychological side of the brain and the physiological side of the brain. So this is a great paper that was published by Van Horn and colleagues in 2020, and I really wanted to read this to you because I think it kind of really does a great job of understanding and explaining what I see with my patients. So in the acute and early stages, the pathophysiology of a concussion is usually dominated by all those things we just talked about earlier in the presentation: physiological cascades, inflammation, the acute stress response, HPA axis. But how does all that have an impact on the brain? And then this is where the paper talks about this neural network dysfunction. In this stage, patients report symptoms such as fatigue, headache, mood changes, and poor concentration. But as time passes, now I'm looking at the red here, psychological processes such as coping styles, which you talked about, personality, emotional regulation have become increasingly influential. Maladaptive and psychological mechanisms likely result in chronic stress, which facilitates long-lasting symptoms. And this is possibly done via this system called the neural network pathway, or the neural network dysfunction. So this is the possible connection between the physiology, the start, the transitions into psychology, and then back and forth. So let's look at what this actually means. The theory is that there's three main networks in the brain. It's obviously super simplistic, self-admittedly. However, it does a good job of kind of explaining this, and I think patients really understand this. When we're just going for a bike ride or going for a walk or driving to work, we're in what's called default mode network. When we are focused, when I'm doing this presentation, for example, if I'm planning something, if I'm talking to a patient, I'm in an executive network. I'm focusing on the task at hand. Just think about this for a second. You could probably break your day up into I'm focused on something, and then there's times when you have opportunities to think and process and review past events. Probably most people are stuck in executive network most of the time. And the salience network helps us switch back and forth between these two. There are specific functional MRI ways of imaging these particular networks, and certain areas of the brain light up with each one of these networks are being activated. Here's where the connection comes into our world, the metabolic world. Again, we talked about, look at the infographic here on the side. Acute injury, you have inflammation, you have oxidative stress, you have heart rate variability, that's the autonomic nervous system, absolutely impacted right off the bat. And then you transition into this overlap between the psychological systems and the physiological symptoms. So now we get into coping, neural networks, prolonged inflammation, prolonged chronic stress. These are all things that we are really good at treating as naturopathic doctors and clinicians that practice functional medicine. So this is a key window in where we can use some of our tools to address the mood, the psychology after a brain injury. But I would say even over and above a brain injury, you can apply this type of thought process to really any sort of trauma, any sort of car accident, and a lot of chronic disease processes, and any sort of acute stress, like think of a cancer diagnosis, and then some of the things that start happening in the body after that. So then once you get dysfunction in these networks, you can have more chronic stress that are leading to more persistent symptoms, and ultimately poor adaptation to injury. So in healthy brains, the default mode network is active. It's occurring, and then as soon as a cognitive task comes up in front of a person, think of this now as a concussion patients, the default mode network shuts off and executive network kicks in. And the salience network does this. However, in concussion, there is this interference that starts happening. So you cannot have the default mode network and the executive network working at the same time. This leads to mental fatigue, lapses in attention, poor cognitive performance. This is called default mode interference. And so what Van Horn and his colleagues and other researchers have found is that concussion, long-term stress, anxiety, again, thinking about a concussion as another stressor, as a trigger to a stressor, over and above just all the nitty-gritty microscopic cellular pathways and cytokines that are being produced, you can see that there is the default mode network is not able to properly shut off. And this ultimately challenges a patient's brain to be able to switch seamlessly back between the executive and the default mode network. And they're kind of stuck in this default mode rather than being able to have cognitive focus. So I found this kind of explanation fascinating. So hopefully I spent a little more time on that just to explain this connection between trauma, stress, injury, acute injury, and working our way into chronic. And so this is a perfect segue into the vagus nerve. And the idea, again, I see this over and over with my patients. And so when Fullscript asked me to do this webinar, I was kind of thinking like, what's the key takeaway that I see with my patients when it comes to mental health and concussions? And I really have to say, it's really in the next couple slides that is the key takeaway point. It really comes down to patients are stuck in mental thought patterns. They're stuck in nervous system modes, default mode network, whatever you want to call it, a combination of all of those. They are stuck in this fight, flight, or freeze mode. And the polyvagal theory, discovered and kind of like described by Dr. Stephen Porges, is a way that our autonomic nervous system scans for cues of safety, danger, and life threat without conscious awareness. And so it's these patients, what I observed is that they're always stuck in this fight or flight. And they're like, I just can't break myself out of it. They're always in this state of higher anxiety. It's not that they're more stressed. In fact, they're off work, they're trying to recover, but they always have this kind of increased feelings of anxiety. And this is where the stages of vagus nerve or polyvagal theory comes in, and the term called neuroception, because neuroception is this kind of just like the first comment and first bullet point discussed, it's like that automatic scanning of our environment. Are we safe? That's the question it asks. Are we safe? And so there's three kind of modes the vagus nerve can be in, or in general, the autonomic nervous system. There can be this dorsal mode, which is like freeze. It's like the super acute, or also super degenerated, lowest on the ladder type of situation. Then there's the sympathetic mode, like fight or flight, and then the freeze is in the dorsal. And then finally, the ventral vagus, which is a higher functioning, the ideal place that a person wants to be for recovery, where there's social interactions, there's engagements, there's connection that's occurring, there's good gut-brain communication. So that's how the vagus nerve and the polyvagal theory and neuroception comes into play. And that really is something that a lot of mental health providers that I'm working with are tackling concussion with. So what about us? What can we do to restore neural network balance, to restore vagus nerve balance? Well, first of all, we have to take a look at what are the things that are causing this? Well, autonomics, inflammation, and oxidative stress. Well, we have some good things that can be helpful of addressing that. And then some specific things, what can we bring the vagus nerve into that more ventral state? Remember, take a look. We want to go up into this state, which is good communication, mindfulness, deep breathing, acupuncture. Again, I have a whole presentation, all this stuff, and you are also really well versed in a lot of these things. A lot of those mind-body practices that you're telling your patients to do. A lot of patients are stuck in only doing things on a very superficial rehabilitatory level. They don't address these underlying issues. And what me and my colleagues have come up with is that you actually need to do that last. You need to do this work and the metabolic work first. And this last, the foundational part of the pyramid is mindset, nervous system hyperarousal, coping, stress reduction, all the things that we've talked about. So what we do know in concussions is that there's this term called dysautonomia that's occurring. A person is stuck in fight or flight mode, or in the worst case scenario, they're stuck in that dorsal state where they're not able to even create a fight or flight response. There's a lot of physiological symptoms that can be associated with this. We know that heart rate variability changes. It becomes less variable after any sort of concussion, after trauma. There's also a lot of signs and symptoms that patients might experience. They might have palpitations, they have insomnia, they have photophobia, they have this low-grade nausea. That's a really important one that's unique to concussion compared to other kind of neurological injuries, and even compared to things like whiplash. And you can't activate the parasympathetic or the sympathetic nervous system at the same time. So what we have to do is we have to find a way, how do we shut off the sympathetic side over here? Because from the locus coeruleus, you can't have both pathways firing into the body. And then there also, you want to increase parasympathetic. So we want to leverage the vagus nerve as a window into the nervous system, into the central nervous system. And hopefully most of you have seen this before. The vagus nerve, when functioning ideally, has potent anti-inflammatory effects. It's called the cholinergic anti-inflammatory pathway. You can see here, there's 3 different ways that it does this, through the spleen, through macrophages, and also the HPA axis. And what you can see here is that there's a number of therapies. This has been well researched, that you can do different therapies to address vagus nerve function. And specifically on the nutritional side of things, good fats are required for vagus nerve function to optimally work. Specifically choline. So things like the keto diet, intermittent fasting, increasing ketogenesis, these are all things that I think have a beneficial effect to having a positive impact on the vagus nerve. And also understand that the main neurotransmitter is acetylcholine when it comes to the vagus nerve. And that is something that we could also increase with some of the things that we have in our toolbox. I mentioned a number of these other ones. Since we're obviously talking about some of the tools we have in our toolbox, it would make sense that we talk about some of the most common nutrients also that are helpful. So things like magnesium are one of my favorites. It's so basic, it's so foundational, but has so many beneficial effects on all the pathophysiological processes that play a role in concussion. It balances calcium and excitotoxicity. We know that levels fall after a concussion. There's been studies on doing it IV acutely, which might have benefit, but you also want to be doing it longer term. Research on reducing depression, anxiety, post-TBI. It has research on depression outside of TBI and on migraines and on headaches. So the mechanistic benefits, the research-based benefits on magnesium are off the charts. What about the types of magnesium? So in my practice, I probably have 5 or 6 different types of magnesium because I truly believe the type matters. Not all magnesiums are created equal when it comes to absorption and also clinical efficacy. The general takeaway point is that magnesium oxide is very poor in absorption, but all the other forms are reasonable forms to get magnesium into the tissue level. However, we can be a little bit more specific by using a form of magnesium that is going to get specifically into the brain. And I actually don't have it here on the list, but one that I use quite a bit is magnesium L-threonate. Magnesium L-threonate, while it is more expensive than a lot of these types of magnesium, there is some animal and some preliminary human evidence to show that it does have a superior ability to get into the central nervous system and have a positive effect. Now, you do have to dose it a little bit higher. Usually I kind of do 2 caps twice a day. Most magnesium L-threonate is standardized because there's a couple, there's one major patented form called Magtine that's on the market, and other forms, they're not the patented version, but they're also available. Generally, the amount of magnesium per capsule is quite low, about like 45 milligrams or so. So you do want to kind of get at least 200 milligrams a day. Even though it has lower amount of magnesium, I do clinically see that it has a superior effect. You could also use magnesium glycinate if you prefer as well. L-theanine, another one of my favorites. Everyone I'm sure on this call has used it before. Maybe you haven't realized how many different health and clinical efficacious benefits it has. You can see I've listed a couple here. There is a lot of, again, mechanistic suggestion for concussion. No specific studies in concussion, while there are on magnesium, not on L-theanine, but it just makes so much sense, especially if we're talking about how to get people out of fight and flight, calm their anxiety, improve their sleep. I love the fact that it doesn't have any interactions with medications, very safe in children, works really, really quickly. But the major obstacle, and this is where I feel a lot of clinicians fall short in gaining the full efficacy of L-theanine, is the dose. Most supplements use a very modest dose of 100 to 200, maybe 250, 25 milligrams, somewhere in there per capsule. And most people take 1 or 2 capsules a day. It's generally really subtle in its effect. So you really have to do higher doses of L-theanine to get the full benefit. So you can go up to 2 capsules twice a day, let's say a 200 milligram capsule. Even 1,000 milligrams of L-theanine is reasonable and safe. So remind us back into this gut-brain connection. Look, remember how important this gut is, especially in modulating neuroinflammation. Again, in summary, the vagus nerve is that key conduit in regulating that inflammation. Becomes dysregulated, dysautonomia after a concussion, and it is the key window that we can use to re-regulate that neuroinflammatory and that gut-brain connection. I did want to point out a couple things, and again, I won't be able to get into this in detail because we're running short on time here, but there is a lot of research being done on the microbiome, the immune, and the gut interface, especially when it comes to mood disorders. You can see here, and I love, I love this recent paper in 2020 looking at how important glia cells, which we talked about, are activated after concussion. They play a crucial role in regulating inflammation, and it's becoming increasingly evidence that the GALTs, which we know as naturopathic doctors really, really well, and intestinal permeability to bacterial LPS, food antigens, that they contribute to the low-grade inflammatory response. So if somebody says, oh, you know what, changing a person's diet has no impact on a person's mood, absolutely not true. There's lots of research now coming out to say that it does play a role in regulating the key cells, the microglia, when it comes to inflammation. Okay, we're in the home stretch here, last couple slides. Okay, so considerations for the gut immune axis. Again, a lot more detail that we can look into this, but from a clinical perspective, I find it most fruitful if a person goes in and starts really aggressively tamping down inflammation, neurogenic inflammation, using curcumin, sulforaphane, resveratrol. You can pick your favorite, but remember, you want to make sure that it gets into the brain. So we'll talk about that in the next slide. And then we want to look at addressing intestinal pathology and are there any obstacles? In my experience, too many clinicians will go in and they will say, well, you know what, L-glutamine is helpful for you, and I want to make sure that your gut-brain axis is working really well. If you focus on that, while that might be helpful in the long term, I don't think that you're going to get good clinical results. Patients want and need to see some sort of therapeutic benefit sooner than later. So my suggestion would be aggressively modulate inflammation, also knowing that a lot of these nutrients, they also modulate the microbiome. There's a lot of now research being looked at in terms of resveratrol and sulforaphane and curcumin, not in its ability to get into a neuron, but also in its ability to modulate the microbiome, and that is the system that then has an impact through the gut-brain connection to modulating inflammation. So there's a lot of different ways that we can address this. However, if a person does have evidence of dysbiosis, major food allergens, major gut symptoms, then I would say this is an area that you should be prioritizing. Curcumin. So, I mean, I could talk about each one of these in a lot of detail, but I just wanted to point out, lots of research on curcumin, animal models mainly when it comes to concussion. This is a good little schematic. But, is it getting into the brain? Is it actually getting into the tissues? I'm skeptical, and this is where my, extensive history working with natural health products in the formulation and the research perspective is that, I think that just because it has turmeric in a product does not mean that it's going to have an anti-inflammatory effect. You really want to be looking at how do we get it into the brain, into the central nervous system ideally. And there are certain formulations, by combining it with a fat, by combining it with certain substances that are going to allow it to have better bioavailability. One of my favorites is using something called a solid lipid curcumin particle, which is combined with phosphatidylcholine. So this is kind of like liposomal curcumin, but not exactly. And this was a study done using this exact form, double-blind, randomized placebo-controlled trial. And again, what I love about this is that one dose within 1 hour, this is what happened. Not that inflammation went down, but they were less tired, and they noticed that these people over 60, they had more calmness. So we think of curcumin as an anti-inflammatory, but I think it's doing a lot more than just having an impact on inflammation. Remember, depression, mood, anxiety are inflammatory conditions. And they did a follow-up study last year looking at, a larger group of people, similar age range, and they found that over that period of time, within 4 weeks, there were statistically significant improvements in anxiety, fatigue, mood disturbance, hostility, confusion. And so again, it should give us further evidence to say that an anti-inflammatory protocol is also a mood beneficial protocol. Okay. And then obviously don't forget about sleep. I mean, I'm not going to tell you other than the fact that it's incredibly important for people that have had concussion because it's a major symptom of theirs. 50% of people over, again, this meta-analysis showed that they had some sort of sleep disturbance. Usually the more severe the concussion, the more disturbed their sleep was. And it doesn't always have to be insomnia. It could be too much sleep. It can be they all of a sudden have a sleep apnea. They might have mood disturbed, dream disturbed sleep. They might have limb movement. So all these things play a key role. And one of my favorites is melatonin. There's a lot of research, recent research showing that it does have beneficial effects both in animals and humans, get past the blood-brain barrier. And don't forget all the other beneficial effects of melatonin. Yes, anti-pain, anxiolytic, specifically linked to mental illness. So we get kind of pigeonholed with like, what does melatonin do? Oh, it helps with sleep. No, it does a lot more than that, just like curcumin. So hopefully, even though I'm not talking about every single therapeutic intervention, because again, we could be here all night, but we can use some of the key foundational principles that we have to address some of the things that are happening on a mechanistic level and also on a sleep and mood level. And then finally, consider saffron if you are not already using it. It's not a very commonly available herb. I mean, I've looked at Fullscript in detail in both Canada and the US, and there's only a few products that are using it. I think that has a tremendous amount of mechanistic actions, no direct research in concussions, but a lot of very applicable mechanisms of action to especially the mood aspect. So it's one of my favorite herbs to use for mood modulation in my patients, both in chronic pain and in concussions, because it's very well tolerated, it has very little side effects, and it is tolerated with SSRIs, and it's kind of like a good entry level herb. And then finally, and I'm not going to talk about this at length because I know that a lot of people that are on this call are very proficient at addressing pituitary issues and hormonal issues. But what we do know is that after a concussion, up to a year after, you could get some sort of deficiency in hormones. And this is what I mentioned, that initial study looking at the acute changes. All those acute changes may resolve, and there may be new ones that pop up after. And again, the key takeaway point is that you could have a thyroid, adrenal, prolactin, gonadal dysfunction, growth hormone dysfunction, months or years after. So testing them right after concussion may not be fruitful. And ones that often get overlooked, in my opinion, are growth hormone. NDs are fairly good at looking at adrenal hormones, and then obviously the gonadotropin hormones. Prolactin's a huge one. So do comprehensive testing to identify this in all your concussion or suspected concussion patients. A lot of vague symptoms, especially when it comes to growth hormone, because that's the one that we typically don't test. But here's a typical panel that I will run with my patients to address. And then obviously worst case scenario is looking at your brain, and you'll actually see the sella turcica, and where the pituitary sits is actually going to have some sort of structural dysfunction. Okay, so to summarize, and I've talked about this already throughout the presentation, so I'm not going to belabor this point. However, remember, you got to have a team. You have to address the complete picture. You can't just look at just changing their diet, even though diet foundational nutrients are really helpful. So come back, look at this, making sure that each one of these things have been addressed. My principles are very much associated with a diet that is easy to stick to in acute concussions, and then having a key nutrient foundation at the right forms, the right doses, getting into the brain properly, making sure that omega-3s, Ds, magnesium are all in play. And then first line in acute cases, and then in PCS cases, you want to look at personalized medicine ultimately at this point. There is not one particular protocol or product that I use for every single one of my patients because it's very personalized. You can probably get a feel for what I start off with, understanding the pathophysiology, but I rarely, and I say this very seriously, I rarely ever use brain product for people with concussion. It simply doesn't work. And usually they've tried it already and they're not going to be getting any sort of therapeutic efficacy from it. The doses are too low, it's too non-specific. What is it really doing? If you want to use a brain mitochondrial product, absolutely, that's really helpful. But understand that needs to be layered on at the right time. If a person can't sleep, they're in a constant state of fight or flight, their autonomic nervous system is dysregulated, giving them a mitochondrial brain product is not going to serve them in any way. They got to be able to sleep, they got to be able to regulate their nervous system, they got to be able to have basic stability in their metabolic system before you can go into some of these other more fancy protocols. So make sure that you take care of the foundations, and really what the whole kind of my clinical practice is something that was really important to me is, I wanted to share this information. So this is a course that I created for patients. So it's everything that I kind of described in this kind of in this pyramid, even throughout the lecture, and broken down into this exact section: mindset, metabolics, and then the manual rehab. And we can do it virtually. So I actually love all my patients to go through this course because they're already eating the diet that they want to be eating. They're already thinking about their mindset in the right way. They understand the basic pathophysiology. Don't underestimate how important it is that if a patient understands what's going on, how they can actually use that information to empower themselves. So I found this really helpful and really fruitful, especially over COVID, to work with patients in the last year. And we've been, again, part of a research study, 50% drop in symptoms after doing the program for 2 to 3 weeks. We can track this before and after. There are thousands of patients that have gone through the program. So this is another resource for people. So Kaylee, I'm going to turn it over to you. I don't know what time we are, but I'm fairly sure that we're over here a little bit. No, we're not too bad.
No, that's okay. And I think we started a couple minutes after 3 my time. So we're good. We have a few questions coming through. So if you have a little time, we can answer some of them or try to get through them. And then if people have to drop off, again, it's being recorded. So everyone will get access to the recording after the event. So there were some questions asked early on in the presentation about concussions in children. So it may have been covered throughout the presentation, but I'm going to read them out anyway. So kind of a basic question: do you think concussions can cause ADHD symptoms in children?
Yeah, that's a good question. What I will say this is that there's research being done at trying to explore if this is potentially a connection. And I haven't looked at the latest because the latest research changes all the time, Kaylee. And so what I will say is that definitely mood disturbances can occur after a concussion. And if a parent has noticed that ADHD has come on after they sustain a brain injury of any sort, then that definitely should be something that they should be considering and looking at how to treat the concussion as one of the underlying root cause factors. So I definitely think that there is a potential connection, and you can probably see based on what I've just talked about, there's a lot of mechanistic reasons why you would want to consider it.
Yeah, and I think that kind of lends to the next question was, what do you see or what do you think about the long-term effects of concussions in children? Which I think can be, whether children or not. I feel like you've kind of touched on the specific and the general long-term effects.
Yeah, and you know what? I apologize. I haven't gleaned the latest research, so there may be some specific studies looking at, does the concussion increase the risk of ADHD? I don't know that off the top of my head, so I can't directly answer that. However, again, mechanistically, I could see that there is a potential reason to increase anxiety that I think is safe for us to say. The long-term risk for ADHD, I don't know if we know that answer. It might be out there, I just haven't seen it.
Mm-hmm. Okay, so another question that came through is kind of a little bit of a longer one. So for someone with a post-concussion syndrome / disorder that's 15 years old and still symptomatic, is recovery still possible with these new discoveries and new information? And how long can recovery be delayed?
Yeah, that's a really good question. A lot of patients that I see are years out after their injury, and I think any clinician will know that the longer a person's removed from the trauma, the greater the chance that some of these symptoms are permanent. And the reason for that is something called central sensitization. And basically, it's if you are living with symptoms like, for example, chronic pain and headaches, then the brain actually creates negative neuroplastic effects. So we see this in our chronic pain practice all the time. So that's definitely something to kind of be considerate of. However, even within that, I think that there are dysfunctions that can be reversed, and central sensitization is very difficult to reverse. However, there can be other additional positive neuroplastic changes that can be implemented. So I think a person may never be back to doing extreme mountain biking or hockey if they have very debilitating symptoms right now, but they could be much more functional. So I think it's hard for me to say it can go back to 100%, especially with being this far away removed from injury. However, we can really improve function, and that is a question mark. We don't know how far we can actually take that. Some people are able to take it all the way. Some people are at the point that they realize, you know what, I know that I'm not going to be able to do certain things anymore. And that's the same thing as like a very catastrophic knee injury that you're going to have to realize, I'm going to have to kind of wear a brace from now on because the structure is just been damaged that much.
Yeah. Okay, another question from a attendee where their interest stems from their granddaughter's soccer, as you had mentioned, soccer brain injury, concussion classified as 3, and major anxiety she suffers now after about 4 years. Is there, or do you think there's a connection with the pituitary gland injury with her brain injury? Or is there a pituitary gland injury?
Yeah, to answer Patty's question, I would say that we definitely, there is a connection with the pituitary gland. And so the simplest thing in this case would be to kind of go through the process of doing a complete workup. So you look at, the testing that I pointed out in the last couple slides here on the endocrine system, and you rule those out because it could be leading to anxiety. It could be contributing to it. However, we won't know until we properly test. So that's what I say. You need to have a full neurological workup. You need to have a full structural and movement workup that is connected to neurology usually. You need to have a full metabolic workup, and you need to also make sure that you are addressing things from a psychological aspect, which is, it seems like Patty's granddaughter has anxiety, so there needs to be a psychology aspect considered and assessed. And there are specific sports psychs, there's clinical psychologists that specialize just in concussion. They can do an assessment, but rule it out, test it. That's how we know.
Yeah. Okay, and on to some, I guess, testing questions, or this one that came through. Do you ever do vagus nerve stimulation with a TENS machine and ear clips?
Yeah. So
again, okay.
like I said, yeah, I personally don't do that because I have other clinicians in my practice that do, or that patients are seeing it. Maybe that's something that my practice will evolve in. And just the way that my practice is set up, I've really tried to focus on addressing the metabolic side of things. But I do know that this can be quite helpful. And I have a number of patients that I'm just thinking off the top of my head that they do some of these therapies, and whether it's TENS to the ear, there's some to the tongue, there's acupuncture, electroacupuncture, there's PONS training is another one that are very, very helpful to reduce symptoms, especially things like migraines, headaches that have been resistant to treatment.
Okay, and this one's a two-parter. So it stems around the controversy around what's considered useful and not useful, accurate, inaccurate, etc. For assessing neurotransmitter levels and ratios, what kind of testing would you say is most reliable these days?
That's a good question. I see that here in the question box. You know, I personally don't assess neurotransmitters other than the basic, I'm going to say organic acid testing to look at, some of the ones that are assessing norepinephrine, some of the like VMA, for example, some of the ones that are assessing dopamine. Over and above that, I don't go into additional testing that might be on a comprehensive organic acid panel. I like to use the ones that have been most validated, and those are the ones that I think are most clinically efficacious.
Yeah.
So I can't really comment on neurotransmitter testing because I don't think it's evolved to the point that we can really use it clinically yet. I also think that if we're following the kind of outline that I shared today, it really addresses neurotransmitter balance more specifically and more, I would say, holistically based on addressing things from a psychological, metabolic, and then finally a manual perspective, rehabilitative perspective. And those little nuances of neurotransmitters will balance themselves out. If you have identified the proper endocrine hormones that are in place, what are deficient, what are excessive, treat those. Any specific deficiencies, nutrients, B6, B12, glutathione, iron, omega-3s, magnesium, vitamin D, all those can be tested quite well. And once you correct those, neurotransmitters usually will regulate themselves. So I think that's a bit too much in the weeds, and I don't think that's been validated enough, in my opinion, to really glean clinical efficacy.
Yeah, that's great. I think lots of information and very clear too about not a lot of research or not a lot of fully fleshed out research at least. There's been a few questions about or coming through about the types of supplements and the dosage. So, I have some thoughts on melatonin and thoughts on glutathione. Do you have, I know you also suggested specific supplements. Do you have a recommended dosage? Do you have a protocol you follow? Something we could potentially share, or is it kind of based on every kind of patient?
Yeah, so I do have an acute protocol that I share with my patients because that one is quite, as you saw in the last couple slides, it's quite specific. And things like creatine, vitamin D, magnesium, those make sense to use as a protocol. After that, I definitely practice kind of what I just shared, is that it's ultra personalized. So, I mean, if you're looking at doses on saffron, 30 milligrams a day is a really good one. I saw a comment here in the question box. It's widely available in food stores. It is widely available, but very unstandardized, and you're not going to get clinical efficacy, I think, in my opinion. There was a research study that looked at, 23 milligrams of saffron a day versus 28, just that subtle difference had no difference in efficacy. So you need the higher dose. And dietary, you really don't get that therapeutic effect. It really pays to be aggressive in terms of the dosing early on. And what I mean by that, I don't mean get somebody into a Herxheimer reaction, especially if you're using glutathione, but definitely with some of the botanicals like curcumin, magnesium, omega-3s, you definitely want to be upping the doses to, kind of limits. And that depends again on the size of the person. And the type of curcumin that you use. So I actually can't even tell you what the milligram amount is, because it varies depending on the particular extract and ingredient that I use.
So interesting. Well, I'm very conscious of people's time, and I know I learned a lot in this. I don't think there's anyone I know that hasn't been touched by a concussion in their life. And then, has had residual effects from it. So I learned a lot in this. I know that from the amount of questions that came through, that our audience also appreciate it. So I will be kind of conscious of everyone's time and let everyone know again that it's being recorded, so you can watch it back whenever you need and whenever you can. But I want to thank you, Dr. Hrkal, for being here today. Another great webinar, and we hope to have more in the future with you.
You're very welcome. Thanks for having me, Kaylee.
All right, everyone. Again, keep an eye on your inbox for the follow-up. Check our website and keep an eye out for hopefully more in the future with Dr. Hrkal. Thanks again for attending and have a great rest of the day.
Thanks, everyone. See ya.